Hello and welcome to the fifth lecture on the basics of hemodynamics. With the learning outcomes from this lecture here, we'll identify how shunts affect stroke volumes. We'll learn how to actually calculate cardiac shunts. And then we'll go through various shunts and the sites for measuring stroke volume for the different types of pathologies that we may see. Then we'll briefly touch on the limitations associated with stroke volume calculations. The evaluation of a cardiac shunt plays an important role in sonography, particularly for pediatric and young adult examinations, where a shunt may be a new finding. Stroke volume calculations can be utilised to assess the flow through the right and left side of the heart, and thus the flow through the pulmonary and systemic circulations. This can be represented as QS and QP. In the normal individual with no shunts, we should expect that QS is equal to QP, that there is a closed circuit with the two working in series or in line. Therefore, what goes through one side of the heart must go through the other. When a cardiac shunt is present, there is an increase of volume of blood moving through either the pulmonary or systemic circuit. In most instances, the left side pressures are greater than that of the right, so the pulmonary side receives the increased volume. The stroke volumes are then compared as a ratio, QP to QS, which may be expressed as stroke volume pulmonary divided by stroke volume systemic. The shunts are considered to be of significance when the ratio is greater than 1.5. For these patients, secondary findings associated with the shunt are most likely to be seen and interventional correction considered. As we are identifying increased volume of blood through moving parts of the heart, this is considered volume overloading, which typically leads to the dilatation of vessels and chambers of the heart. Measuring the circuit flow is done with the stroke volume calculation. Q, which is flow, is equal to cross-sectional area times the velocity time integral. When the measurements are performed, vary on the location of the shunt. The QP must be taken distal to the shunt, directed to the lungs, and therefore hold the extra volume of blood. The normal stroke volume plus the shunt volume. The QS is measured distal to the shunt on the systemic circulation. In an example of an ASD, an atrial septal defect, a sonographer can use the right ventricular outflow tract, the main pulmonary artery, or tricuspid valve as sites to sample and obtain the QP volume estimates. Note, the order shown is the site preference and not the continual directional flow. It is important to note that pulse wave Doppler is used and the correct sample volume positioning along with modal velocity tracing is used. The cross-section area must also be measured at the appropriate time in the cardiac cycle. For the right ventricular outflow tract diameter, we want to measure it mid-systole, the same time that we expect the peak for the VTI to occur. The QS can then be measured from the left ventricular outflow tract, the ascending aorta, or mitral valve. Again, here is the order of preference that is shown. The atrioventricular valves are chosen lastly for the difficulty in attaining the true diameter and the elliptical shape they have, rather than a true circular form, which leads an error for the calculation. With significant atrial septal defects, the patient will display a dilated right atrium and dilated right ventricle. The flow between the atria is passive. Typically, higher pressure in the left atrium directs flow into the right atrium. The flow may be continuous or intermittent, associated with atrial filling and increasing pressures. The atrium is a filling chamber or reservoir, so it dilates due to the extra volume. The right ventricle dilates in response to the volume overload that we see. In rare instances, a patient may have Eisenmenger syndrome, in which case the right heart pressures rival that of the left heart, and so right to left shunting may be demonstrated. Ventricular septal defects are measured in a similar manner. However, now the shunt is at the level of the ventricles. The locations for measuring the QP may be the right ventricular outflow tract, the main pulmonary artery, or the mitral valve. Note how the mitral valve may be used even though it is on the left side of the heart. This is because it has the extra volume of blood in the pulmonary circulation that has passed through the lungs and through the mitral valve proximal or prior to the shunt itself. The QS then may be measured from the left ventricular outflow tract, the ascending aorta, and the tricuspid valve. Again, we see the potential to use the tricuspid valve even though it's associated on the right side of the heart. In a significant ventricular septal defect, we see that the left ventricle and the left atrium are dilated. Even though there is left to right shunting, the flow occurs insistently when the right ventricle is emptying. The flow then moves through the pulmonary circulation and back into the left heart, therefore creating the volume overload pattern on the left side. Many sonographers struggle with the understanding that goes with the sampling of shunts for the patent ductus arteriosus calculations. In this instance, the shunt is extracardiac between the aorta and typically the left pulmonary artery. Thus, the sites for sampling the extracardiac shunt volume in the QP are the LVOT, ascending aorta, and mitral valve, all left heart circulatory structures. The QS is then measured either from the right ventricular outflow tract, main pulmonary artery, or tricuspid valve, all of which are right circulatory structures. They are all considered distal to the shunt and therefore have the reduced stroke volume. As with the VSD shunt, the presence of a PDA, we expect to see left atrial and left ventricular dilatation associated with the increased flow from shunting moving through the pulmonary circulation and then back into the left heart. In this particular example here, we've actually got a short axis of the heart, aortic valve here, left atrium, right ventricular outflow tract, pulmonary valve, and the main pulmonary artery. So the main pulmonary artery descends down, the right branches off this way, the left comes down here, and we have the aorta shunting into the pulmonary artery. So putting our calculations into practice, here we have an example of an ASD. Consider that the LVOT velocity time integral is 19 centimeters and the LVOT diameter was 2 centimeters. Then we put our sample volume into the right ventricular outflow tract and we measured a velocity time integral of 18 centimeters and a right ventricular outflow diameter of 2.3. So QP to QS ratio, 18 times 3.4 times 1.15 squared to the ratio of 19 times 3.4 times 1 squared. So 75 to 60, basically 75 divided by 60 equals 1.3 or 1.3 to 1. There are assumptions and considerations associated with these calculations, and those are the same that were previously described for stroke volume calculations. These are the errors occurring with obtaining velocity time integrals, errors in obtaining the diameter measurements, and assumptions associated with volumetric flow calculations on the basic hydraulic principle of uniform flow through a cylindrical tube. It is important to note there are two sets of stroke volume calculations, thus there is double the potential for error to occur. It can be seen that even when no shunt exists, the stroke volume calculation method can actually give a shunt ratio, and this is representative of our assumptions. In summary, shunt calculations are commonly used in pediatric and young adults. They may not have had previous screening, or a murmur or split S2 sound may be heard. We've explored the three main forms of shunting of an ASD, a VSD, or PDA. Consider there could be other types, such as VSDs can be further broken down into classifications, which will be covered later in the course. Consider there could be other forms of shunting, such as fistulas, where the aorta could connect to the right atrium. However, these are rare and it's fairly advanced stuff, so we won't actually cover it at this stage. We can establish that we need to make measurements to measure the shunt severity. Each of QP and QS measurements need to be made distal to the shunt itself. Don't forget that PDA is an extracardiac shunt, and what would normally be used for pulmonary stroke volume instead becomes the QS. And the QP-QS is bound by the same stroke volume limitations and assumptions, including error by the user and machine setup problems.